you so much for the introduction. I would also like to thank the Academy of Research and my nominators, Dr. Beth Skidmore, Ken Ottenbacher, and Janet Poole, for this recognition of the importance of this work. I also want to thank the Academy of Research for the invitation to join the Academy. Next, I would like to thank all of the stakeholders that have been collaborators and partners through all of this research that I'm going to share with you today. All of these individuals have made significant contributions to the work, and we would have not have been able to make the impact we have without each of their contributions. So thank you to all of those individuals. Next, I would like to acknowledge all of the funders who have supported this work over the years, including the Agency for Healthcare Research and Quality, the National Institute of Aging, NICHD, PCORI, SCAN Foundation, and the California Department of Health and Social Services. I would like to ground this research talk by sharing a little bit about my early practice as an occupational therapist in skilled nursing facilities. Those early experiences have shaped the questions I continue to ask to this day. As an emerging occupational therapist, more than 20 years ago, I worked in many regions of the country. I saw variations in local practice culture, inconsistent use of evidence-based practice, and healthcare inequalities. Patients with similar healthcare needs did not have the same access, receive the same services, or achieve similar desired outcomes. Further, I witnessed firsthand how national policy was impacting how and when I could work with my patients. These experiences were reflected in the seminal reports that were published by the National Academy of Medicine, at that time referenced or referred to as the Institute of Medicine. Their 2001 Quality Chasm Report and the 2002 Unequal Treatment Report both document gaps in quality of care and the systemic inequalities that continue to persist to this day. These reports reaffirmed the experiences I had were not just isolated to the patients and my own experiences. In fact, there were widespread issues that needed to be addressed if we were going to ensure that the patients we all care about achieve the goals and outcomes that they would like. These ongoing challenges with gaps in quality of care and inequalities are only some of the transitions that we have been experiencing in the US healthcare system. Over the last 12, 15 years, we're also experiencing the transition from a healthcare system that operated on a fee-for-service model, which incentivized payment based on the number of services, the intensity of therapy services, to one that now links payment to quality of care and patient characteristics. As we think about where the future holds, we need to continue to monitor policies and understand what the implications of these policies are for the patients that we care for, as well as the ability for us to provide the services that we have developed a strong evidence base for. Further, we need to continue to monitor the quality measures that are being developed that are used to link payment to performance for health systems. The examples here on this slide are just a few of the examples of health system quality measures that health systems are held accountable for. Hospital readmissions, when we think about the proportion of patients that are readmitted within a 30-day period. Or discharge function. What is the proportion of patients that experience a change in function during their post-acute care stay? This transition to a value-based healthcare system has implications for occupational therapy. This value proposition requires us to ensure that we have effective clinical interventions. We need to ensure that those evidence-based interventions are contributing to the achievement of desired patient outcomes and also helping to mitigate adverse outcomes. We also, as a profession, need to think about contributing to and developing quality measures that reflect the care priorities and preferences of the patients we care for. As we think to addressing gaps in quality of care, we also need to ensure that we are implementing and systematically delivering these evidence-based occupational therapy practices across all patients who would benefit from them, to ensure the delivery of high quality care and ensure that we are mitigating health disparities. So as we think about the evolution of policy over the last 20 years or so, my research has tried to be a response to those changes in healthcare policy. My questions have really lived at the intersection of health services research and implementation science. My work has tried to quantify patient prioritized post-acute care health system outcomes, to examine the impact of emerging policies on the patients we care for, including access, care quality, and outcomes. We have also tried to develop evidence to move forward as we try to decrease gaps in healthcare quality by elevating voices of stakeholders and driving implementation of evidence into practice. And today I'm going to share a few examples of these projects with you. First, I'd like to share some of my early work, which aimed to align concepts that were emerging in the quality measure development world with priorities of the post-acute care stakeholders that I serve. The first example is looking at successful community discharge. So in 2009, there was a seminal New England Journal of Medicine paper written by Jenks and colleagues that looked at readmissions among acute care patients that were Medicare beneficiaries. In this paper, it was determined that 20% of readmissions could be prevented. This was a key study that has driven the development of the hospital readmission quality measure that is now linked to payment. When this paper came out in 2009, what stood out to me as a clinician working in skilled nursing facilities was that my patients were not included. In fact, they were systematically excluded from the sample. The sample only looked at acute care discharges to the community. So I asked myself, what about the post-acute care patients? They want to go home as well. How can we operationalize a value concept that reflects the community transition experience of our patients? And it was that question that drove this work, where we looked at 880,000 Medicare beneficiaries, all of which had been admitted to an acute care hospital for a hip fracture and were discharged to post-acute care. We wanted to know, when they leave that first post-acute care setting, to what extent are individuals discharged back to the community? How many of them are able to get to the community and stay there 30 days, which is what we called successful community discharge? How many had a failed transition during that initial 30-day window and re-entered the healthcare system? In fact, we found that 14% of those community discharges failed. But unlike the cohort in the Jenks paper that were only being readmitted to an acute care hospital, because of the structure of the Medicare benefit, these failed community discharges among post-acute care patients, they were able to re-enter the healthcare system through many doors. And so just having a hospital readmission measure was not capturing the failed transitions among all of our post-acute care patients. This work also helped us to quantify that health disparities do exist among non-white older adults. We found differences in terms of achieving successful community discharge among Blacks and African Americans relative to their white peers. We also found evidence of geographic variation. Where you received your post-acute care after hip fracture was associated with the likelihood of achieving successful community discharge. Around the same time, there was also a growing interest in capturing quality measures that reflected adverse events, so events that we do not want to happen. Accidental falls is one of those for post-acute care. As a clinician, preventing falls was a ongoing challenge. But when I had gone to the literature to look for strategies for preventing falls, or even to understand what is the current rate of falls among this patient population, I had found no evidence as a clinician. So as a researcher, we began to explore that question. What proportion of newly admitted post-acute care patients fall when they're in a skilled nursing facility? In fact, we found that falls were very common. More than 20% of older adults experience a fall after being admitted to a skilled nursing facility. We also wanted to know, what are the outcomes when that older adult not only falls in the facility, but experiences a hip fracture? We then followed a cohort of older adults who had that experience. They fell during their post-acute care stay in a skilled nursing facility, broke their hip, were admitted to a hospital, and then we followed their path of care. We found in the 90-day outcomes after the hip fracture hospital discharge that more than 24% of the patients had died. Only 14% achieved successful community discharge. 7.3% experienced a failed community transition, and more than 50% of the cohort was still in a healthcare institution at 90 days. This work further reinforced not only are accidental falls common during a post-acute care stay, but major falls, which is now a quality measure, is a significant event that results in very poor outcomes and a very low likelihood of returning to the community. We have also been engaging in some research that is funded by the National Institute on Aging to understand how emerging post-acute care policies are impacting patient access, care quality, and outcomes. In skilled nursing facilities and home health, 80% of Medicare post-acute care spending is made up of care for Medicare beneficiaries in these two settings. When I was a clinician, the payment model that was in place was the prospective payment model. In this payment model, the greater the intensity of services, the higher the payment. So this incentivized the delivery of higher intensity services because that brought in a higher payment. The new payment models that were implemented recently are designed differently. They've removed the incentive or link between the intensity of services and payment. Instead, the new models have been designed where facility payments are designed based on patient characteristics at admission. The patient-driven payment model was implemented in skilled nursing facilities in October of 2019. And then in home health, the patient-driven groupings model, or PDGM, was implemented in January of 2020. While these two models have provided the opportunity to transition from a volume-based payment model to one that is now informed by patient characteristics, there were a series of stakeholder concerns that were raised during the technical expert panels starting in 2015, when the concepts behind these models began to be developed. For example, while stakeholders recognized the importance of removing this incentive to deliver high intensity therapy, the concern was raised that there is not a control for quality built into the payment model. While there have been value-based payment initiatives, they are not embedded in this system. In fact, they are additional programs that providers have to report to. Further, stakeholders raised concerns that by structuring a payment model based on patient characteristics, that there may be differential impact for certain patient populations with regard to access to care, the quality of care, and the outcomes. One stakeholder had even attributed this to there's going to be winners and losers when it comes to this payment model. So in response, our current R01 is trying to understand to what extent those stakeholder concerns are in fact concerns we need to address, or these potential unintended consequences that were raised did not in fact occur. Our initial work wanted to understand how staffing levels changed during this time. For those of you who may remember, Centers for Medicare and Medicaid Services actually announced this payment model being implemented in skilled nursing facilities almost 2 years prior to the implementation in October of 2019. So in our analysis, we looked at the staffing levels from January 2019 through March of 2020, with the implementation occurring right here in October of 2019. And you can see while there had been a decline in therapy staffing across disciplines throughout the entire year, on October 1, there was a dramatic decline in staffing across the country. So this is just one example of how, as a profession, we need to continue to be aware of policy changes and proactively engage in research to better understand the impact of these policies on staffing levels, patient access, quality of care, and outcomes. So stay tuned for further findings as our project evolves. Up to this point, I've shared with you some examples of research where we have measured quality of care, we've determined gaps in care quality, and lots of room for improvement as we think about fostering a safe community discharge for individuals with a hip fracture, preventing accidental falls. But we need to move beyond measuring a problem and start thinking about how do we systematically support the implementation of best practice into the clinic so we can improve those bad outcomes and enhance care quality. So a few examples of this work are related again to my older adult patients who've had a hip fracture. From the work I already presented, using Medicare data, we know that there's a problem with quality of care, but the Medicare data did not provide us and doesn't have the opportunity to dive into what care was provided so we can start to figure out how do we fix it. So we started engaging with our stakeholders and conducting a series of qualitative studies to better understand what are provider perspectives on best practice. Because at the time the study was done, there weren't any post-acute care practice guidelines that delineated what occupational therapy providers should be doing, what physical therapy providers should be doing, what nursing should be doing as a collective team. The practice guidelines that existed had very detailed strategies for the acute care stay, but they weren't as developed when it came to the post-acute care part of the recovery process. They all asserted that there was evidence of multidisciplinary rehabilitation being an important part of the recovery, but there was no details behind that. So from this work, we started engaging with stakeholders, hearing from providers around the country to better understand how each member of the care team works together to prevent falls, to foster that community discharge. We heard about the importance of patient-caregiver collaboration in developing the plan of care, getting the patients up and moving early, preventing falls, addressing fear of falling, addressing habits, roles, and routines, looking at the home environment, addressing home safety, and collaborating with the broader care team to address the medical issues, managing pain, so that they can continue to actively engage in the rehab sessions. We also wanted to better understand, how does the interdisciplinary team communicate with each other? How do the rehabilitation providers, OT, PT, speech, how do they work with nursing for individuals who've had a hip fracture to ensure that the patients are managing their pain, that they're able to get up, to mobilize, and begin that recovery process so they can get home and stay home. And this work in this publication aimed to try to better understand the importance of that communication across the care team. And finally, an example of an implementation study. Center for Medicare and Medicaid Services, I think back in about 5 years ago, prioritized the reduction of off-label psychotropic medication for nursing home residents with dementia. They wanted to reduce the reliance of this medication and instead have opportunities for non-pharmacological approaches to manage the neuropsychiatric symptoms that often emerge as the disease progresses, such as agitation, aggression, that come as the disease progresses. So again, in collaboration with the nursing home community, we developed a proposal to better understand what is the right way to equip staff in a nursing home with the appropriate strategies, recognizing this is not up to one discipline, but it's going to require all of the members of the nursing home staff to work together. This means ensuring that approaches are accessible to all of those different types of staff, regardless of their education level, their job roles, their health literacy, that we can empower everyone who comes across the residence to have the same strategies. And that these strategies can be delivered regardless of the nursing home context, what state they're in, what the national training requirements are, or constraints of the built environment. And through this work and through COVID, we have continued to answer this question and will hopefully have results in about 18 months. So as I think about my work to date and where we can go in the future, I think that we need to continue to understand and explore the interplay between policy, research, and practice. We must continue to demonstrate our value as part of that interdisciplinary team. We need to proactively develop policy relevant research to identify policy initiatives, such as the one that CMS had around enhancing the use of non-pharmacological approaches. Occupational therapy can have a significant role to play in a variety of national healthcare policy initiatives, but we need to be proactive as we think about those and as they emerge. We need to examine how emerging healthcare policies impact our patients and their caregivers, as well as providers and other key stakeholders. We also need to think to the future and think about what are the unintended consequences of policies and different initiatives. How do we ensure that our patients are continuing to get the care that they need? We also need to move beyond measuring healthcare quality and health disparities and start developing multi-level health system interventions that address the barriers to health equity. Understanding better the role of social determinants of health, understanding the intersectionality of our clients' multiple social identities and how for some that intersection of those social identities may put them at greater risk of health disparities. And continuing to understand the lived experiences of our patients and their caregivers as we think about and design and work collaboratively with them to address these multi-level health equity interventions. And finally, continue to advance the systematic implementation of evidence into practice. So with that, thank you for listening to this work. Thank you to the American Occupational Therapy Foundation and to the Academy of Research for the recognition of this work.